Vaccination, antibiotics, and improvements in public sanitation. These are things that my generation have taken for granted. As healthcare professionals, we're becoming increasingly aware of the challenge that antimicrobial resistance is going to pose. On a daily basis, we're already dealing with identifying and treating multi-drug resistant organisms and treating antibiotic-associated diseases such as Clostridium difficile infection. Over the next 10 minutes, the infection control team are going to try and impart as much information as possible around standard infection control precautions and antimicrobial prescribing. All we can do is signpost you to a whole raft of other information. There's plenty of information out there if you look for it. Our infection control teams are based on each of the acute hospital sites. Please take time to get to know them. They're there to help, support and advise you during your time at ABMU. Thank you.
ABMU has a zero tolerance to avoidable healthcare-associated infections. All staff are expected to adhere to infection and prevention control protocols and policies. In particular, standard infection control precautions are to be applied by all staff with all patients at all times in all healthcare settings. 30% of all healthcare-associated infections are considered to be avoidable through better application of existing knowledge and realistic infection control practices. There are several infection prevention and control policies which can be found on the intranet. From the home page, click on Clinical Systems, COIN, Specialities Infection Control. These policies cover many aspects of infection prevention and control practices, including hand hygiene is considered to be the single most important practice in reducing transmission of infection. While in clinical practice and before performing hand hygiene, all clinical staff must be bare below elbows, fingernails must be kept short and clean with no artificial nails or nail art. Also ensure all broken skin is covered with a waterproof dressing. Hand hygiene must be performed in line with standard infection control policy. Videos on the correct hand washing technique are available online. If you experience any adverse skin reactions, report this to Occupational Health for further support and investigation. Annual training on the use of the correct hand hygiene technique is part of ABMU's mandatory training programme. Each ward and unit runs hand hygiene training sessions using the Glow and Tell light box. If you have not been trained recently, please ask the ward or unit manager for the next training session, or you could volunteer to be a trainer yourself. Each month, wards and departments carry out quality assurance audits on compliance with hand hygiene using the WHO 5 moments. Repeated non-compliers are managed within the disciplinary policy. In addition to standard precautions policy, the transmissions-based precaution policy contains a table indicating what precautions should be taken based on confirmed or suspected infections. This includes what personal protective equipment, or PPE, should be used. PPE can help protect your clothing, your skin and mucous membranes from blood, body fluids, secretions and excretions. PPE is chosen on the basis of a risk of potential contamination. Before each procedure, we should be asking ourselves, am I going to be in contact with blood or body fluids? Will I need to have very close body contact, which could contaminate my clothing, skin or mucous membranes? In order for PPE to be effective, it must be applied and removed correctly. Hand decontamination before applying PPE and after its removal is imperative. Please note, if you need to wear a FFP3 respirator, you must have been trained in how to use them. FFP3 masks should not be removed in the patient's room, as this would put you at risk. You should check these isolation door signs to guide you on what PPE is necessary. Patients admitted with diarrhea and vomiting need to be promptly assessed for the likely cause. The norovirus toolkit contains single-page assessments for both unplanned admissions and current inpatients. These assessments help to establish whether symptoms are normal for the patient, chronic and ongoing, or whether these symptoms are of sudden onset and unexplained, which may indicate a norovirus infection. Prompt communication of this important information and isolation is essential to ensure beds are not closed unnecessarily and that patient flow is maintained. Patients suspected or confirmed as Clostridium difficile infection should be isolated within 2 hours of diagnosis. The Clostridium difficile policy can be found on COIN, along with the disease severity metrics and associated treatment algorithms. These tools can guide you in assessing the severity of the patient's illness and help in choosing effective treatment. The policy also includes a proforma, which should record your daily assessments of the patient. This will assist in assessing and reviewing if your patient is responding to the prescribed treatment. The MRSA policy contains a pre-written prescription chart for MRSA decolonisation treatment. When infections such as Clostridium difficile, Staph aureus bacteremias and E. coli bacteremias are considered to be acquired in hospital, you will be asked to give your expert input into undertaking a clinical case review and identifying contributory causes. You will play a pivotal role in identifying good practice in the patient's pathway, and importantly, exploring and sharing if there are any gaps in practice which require further support in order to avoid a further episode of harm in other patients. Your health is important. We encourage you and all of your staff to be vaccinated against flu. If you experience DNV of unknown origin, please follow the sickness policy, in that you should refrain from work until you are 48 hours symptom-free. Always follow Safer Sharps practice and use Safer Sharps devices where these are available. Take Sharps boxes to the point of use and dispose of your Sharps safely. You are responsible for disposing of your own Sharps. ABMU promotes the STOP campaign. Think before you insert any device. Remember, urinary and vascular catheters all increase the risk of infection. The risk increases for each day the device remains in situ. The need for each device should be reviewed daily. Remove devices as soon as they are no longer needed. This reduces the risk of invasive infections and possible sepsis. A single-use licensed product containing 2% chlorhexidine in 70% isopropyl alcohol should be used for skin preparation on insertion of peripheral and central lines and preparation of the skin before taking any blood cultures. All essential devices should be inserted and managed as per care bundle. We have pre-packed peripheral vascular cannula insertion equipment with detachable stickers to help you comply with the care and management bundles. Blood culture packs are also available. ABMU expects all clinical staff to have been recently trained in ANTT, aseptic non-touch technique. Training is available online. Always follow the basic principles of asepsis to reduce the risk of infection for our patients. The ABMU antimicrobial guidelines are available via the intranet. A treatment guideline app can also be downloaded on Apple and Android devices. The main principle of antimicrobial prescribing is to start smart, then focus, which encourages prudent antibiotic prescribing, which in turn helps to prevent Clostridium difficile and reduces the risk of developing multi-resistant bacteria. Start smart means only use antibiotics if there is a clear evidence of infection. Obtain cultures prior to commencing antibiotic therapy. For patients with severe sepsis or life-threatening infection, start the antibiotics within 1 hour of diagnosis or as soon as possible thereafter. Check local guidelines, document the indication and the review date in the notes and drug charts. Then focus means at 48 to 72 hours, the sample results should be available, including the culture and sensitivities. Review the clinical diagnosis and the need for continuing the antibiotics. Document the decisions you make. Options include stopping antibiotics if no evidence of infection, IV to oral switch, change antibiotics to something more narrow spectrum. This will obviously depend on the culture and sensitivities. The new ABM drug chart has a dedicated antibiotics section to improve antibiotic prescribing. Proton pump inhibitors, or PPIs, should also be reviewed on admission, and especially if the patient is receiving antibiotics. This will help to reduce the incidence of developing Clostridium difficile infection. Acid suppression guidelines are also available on COIN. Consultant microbiologists and antimicrobial pharmacists undertake antimicrobial ward rounds in some areas. Microbiologist support is available through Switchboard 24 hours a day. Finally, may I take this opportunity to welcome you to ABMU, where infection prevention and control is everybody's business. We mirror the Health Board's values in working together as one big team to ensure we all care for each other, both staff and patients. And we always strive to improve our practices by sharing and learning from the clinical case reviews of healthcare-acquired infections. Thank you for your time and attention, and please do not hesitate to contact us for further information and support.